Good afternoon. Okay, we'll start. First of all, I'd like to welcome everybody to this pep talk today. Please mute yourself, but always show your video picture. Sign in your name, your Facebook account, if you have, an email address in the chat box. Please include the names of the companions attending. Use the chat box to ask questions and make comments while the pep talk is on. There'll be group pictures at the start and end of the pep talk. Please show your face in the video during the picture taking. As a reminder, also, please take the online learning evaluation test exercise or OLETE for mastery of learning and have a perfect score to get this certificate. I have placed the link in the Facebook page. Okay. I think Abed has also placed the link in the chat box. Another reminder is that for 50 OLETE certificates, one is entitled to have a voucher for a ROJoson telemedical consultation. So let's now have a group picture taking before we start the pep talk proper. Okay, please show your face. Are you all ready? Okay. Perla, I'd like you to show your face, Perla. Okay. Ready? 1, 2, 3. Okay. Pahabol si Mayan. Let's start. 1, 2, 1, 2, 3. Okay, let's start. Okay. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the pep talk. I completed the core course on October 9, 2021, last year. After October 23 onwards, I have been tackling health disorder and health issue courses. This may take 3 years or longer. Last March 19, I started with this module on abdomen. So I started with abdominal disorders, an overview, in which I talk about the 5 common abdominal disorders: abdominal pain, mass, obstruction, bleeding, and jaundice. Today we will be tackling abdominal obstruction as a disorder. So my pep talk today is entitled Fundamentals and Generalities in the Medical Management of Abdominal Obstruction, an overview. This is part of the health disorder course. Okay. The empowerment objective is for the lay people to have an understanding of the fundamentals and generalities in the medical management of abdominal obstruction. Definition of terms in the title and the limitation in the coverage of my talk. The word fundamentals to mean the simplest and essential facts and theories which can serve as a basis or foundation and support for future advanced information. And generalities to mean general statements of information, not covering specifics and details. And medical management, diagnosis, and treatment usually done by physicians. So the content of this particular talk on abdominal obstruction will be the following. What is an abdominal obstruction? The different types, causes, how common are the abdominal obstructions, clinical diagnosis, paraclinical diagnostic procedures usually being done, and then the basic treatment modalities for abdominal obstruction. So just fundamentals and generalities. So let's start with the first topic. What is an abdominal obstruction? Simply put, or in Tagalog, obstruction means barado. Barado. Okay. Obstruction means there's a block or blockage that impedes or prevents the passage of substances such as food, fluid, okay, and fluid can be water, bile, or urine in the human body. So to pass, which impedes the passage of these substances to pass through a usual passage way, such as the gastrointestinal tract, the stomach, the intestine, the biliary tree, and urinary tract, etc. Okay. What are the different types of abdominal obstructions? So when you say obstruction, abdominal obstruction, we're referring to the obstruction inside the abdomen. Okay. So there are three types: gastrointestinal tract obstruction, biliary tract obstruction, and urinary tract obstruction. The three more common types of abdominal obstructions in the human body. So here are illustrations of gastrointestinal tract obstruction. Okay. So here there's a block here at the end of the stomach. So you have this tension of the stomach. Okay. Just before the block, so there's this tension of this stomach. Okay. And then here there's a block here of the small intestine. Okay. Whenever there's a block here, there's usually this tension of the upper part of the intestine. Okay. So here is showing a block in the colon, okay, large bowel, okay, showing this tension of the upper part of the colon. Okay. So these are examples of gastrointestinal tract obstruction. Gastro means stomach. Intestine can be small intestine and large intestine. Biliary tract obstruction means this is the whole system of the biliary tree. You have the gallbladder and then the ducts. Okay, so you have the common bile duct. You have the hepatic duct, which means the ducts coming from the liver. And then you have the pancreas here, in which you have a pancreatic duct here. And all of this leads to a drainage into the small intestine. Okay. So example of biliary tract obstruction, you may have a gallstones, which might cause blockage of the gallbladder, the first block. Or if the gallstone has gone into the common bile duct, then you have the gallstone blocking the common bile duct. Then if you have a gallstone down here, it may also cause blockage of the pancreatic duct. Okay. Urinary tract obstruction just means, okay, this is the kidney, the ureter, and the bladder. Okay. So an obstruction here could be a stricture or stones in the ureter. So there's a buildup of the urine of the upper part of the urinary tract. Okay, as far as the as high as the kidney. Okay, so this could be the effect of the obstruction in the ureter. Okay, so the obstruction can be anywhere. It can be down here, can be down here. Okay, and even down here in the prostate for the male. Okay. So what are the causes of the abdominal obstruction? Basically, the general causes are tumors, which could be cancer or not cancer, stones, adhesions, intussusceptions, volvulus, and stricture. So these are the more common causes of abdominal obstruction in general. Okay. Now, for the relative frequency of the causes, let's say for the gastrointestinal tract, the most common cause of obstruction is the tumor. Okay. And then for the biliary tract, and urinary tract, it's the stones, which are the most common causes of obstruction. Okay, and this shows that the relative frequency of the other causes. Okay, adhesions usually seen in intestinal obstruction, gastrointestinal, intussusception, intestine, usually not in the biliary tract or urinary tract. Volvulus, okay, also seen in the gastrointestinal tract, but it's not as common as the tumor, adhesions, and intussusception. Okay, volvulus is not seen in the biliary tract or urinary tract. Stones are most common in biliary tract and urinary tract, but sometimes, rarely, it can cause also obstruction in the gastrointestinal tract. Okay, so a stricture is usually seen in biliary and urinary tract, rarely or not so common in gastrointestinal tract. Okay, so this shows the relative frequency of the causes in the various tracts. So this is an illustration of a tumor causing gastrointestinal obstruction. So you can have a tumor here. Okay, if it grows big enough to occupy the whole stomach, then it will cause obstruction. Okay. Also here, a tumor in the small intestine. Okay. If it goes inside and then impedes, completely block it, then you will have distension of the proximal intestine. And here's an example of a colonic tumor, okay, large intestine, which may cause obstruction. Tumor causing biliary tract obstruction. So usually you have a head of the pancreas tumor, okay, causing obstruction of the common bile duct. Okay. Sometimes you can also rarely can have tumors in the common bile duct itself. Okay, here, so it can cause obstruction. So the bile from up the liver will not be able to go through. Tumor of the causing urinary tract obstruction. You can have a tumor here in the bladder. If it grows bigger and bigger, then it can also cause obstruction, especially at the opening of the ureter. Okay. And then the other common type of obstruction, urinary tract obstruction, especially in males, is the prostate, causing obstruction. Stones. This time, stones causing biliary tract obstruction. You have the stone here, stone there, or anywhere in this whole length of the common bile duct. Stones causing urinary tract obstruction. Okay, you can have stones in the ureter, the most very common. Okay, causing obstruction. Adhesions. Usually after an operation, there may occur some adhesions, meaning mga bituka dumidikit-dikit na. Okay, so this is an illustration of the adhesions in the abdomen. So once you have admissions, okay, you can cause such a situation, obstruction of a loop of his intestine. Okay. Intussusception. Okay. This is not so common, but it happens. So it just means one segment of the intestine, one segment, telescope, pumasok lang siya inside the other side, and the other part of the intestine, papasok lang siya dyan. Okay, so causing, pag naipit dito, so you will have distension of this part of the intestine. Parang ganito, okay? So this one, hindi makapasok yan, na? Okay? So this is intussusception. Volvulus, meaning nag-twist lang yung bowels, okay? By its, along its axis, nag-twist lang siya because of probably masyadong mahaba, no, redundant, no, okay, so nag-twist lang. Okay. Stricture means, okay, narrow passageway. This is a stricture in the biliary tree. Okay, walang bukol, okay, walang stones, but because of probably of some inflammation, o kung minsan may operation, nagkakaroon lang stricture. Okay. So this shows the stricture in the common bile duct causing obstruction. Kaya malaki yung mga bile ducts up there in the intestine, in the liver. Stricture in the ureter dito. Okay. So not stone but stricture. So you can cause urinary tract obstruction. So again, this just shows the relative frequency of the various types of general causes. Okay, to repeat, tumors is the most common cause of gastrointestinal tract obstruction. Stones, okay, and is most common in the biliary tract, and then also common in the urinary tract. So how common are the obstructions? Quite common. Okay. Very common in life, but know that we don't have any exact data which one's the most common. Probably the gastrointestinal tract obstruction is most common. Comes next will be the biliary tract and then the urinary tract obstructions. Okay, but these are just personal observation. So I said tumors, gastrointestinal tract, stones, biliary tract, stones, urinary tract. So clinical diagnosis of abdominal obstruction. The starting point in the evaluation of a patient with possible abdominal obstruction is that the patient has an unpleasant sensation or pain in the abdomen, okay, with no history of trauma. Then we will see if there is abdominal obstruction or not. No. So, but before we go to the more detailed process in trying to diagnose abdominal obstruction, let me say that these are the basic evaluation methods in all patients with abdominal problem. History taking to get symptoms, physical examination to get signs, data. Okay. After you get the symptom and sign data, you process all the data to come out with the so-called clinical diagnosis. Okay. So the basic data that is needed in the history taking will be when the initial symptoms were noted, then what was the subsequent course, okay, and then any associated symptoms. Okay. In the examination naman, so the basic data needed will be look and palpate. So look for the bulge, look for distension, palpate for a mass, palpate for tenderness or pain. So these are the basic data that is needed to evaluate a patient with an abdominal problem. Okay. The cues that one is dealing with gastrointestinal obstruction are the following. There are gastrointestinal symptoms like pain, vomiting, abdominal distension, and no bowel movement. In the biliary tract obstruction, the cues will be jaundice, yung naninilaw ang mata, okay? If there is pain, usually it's caused by obstruction. Kuminsan, the jaundice is there, but it's not painful. So it could be not a biliary tract obstruction, but the so-called medical jaundice, like hepatitis, okay? For the urinary tract obstruction, pain is a very frequent symptom, okay, that pain during urination, okay, so the patient also has urinary symptoms, okay. So these are the cues for the three types of obstruction: gastrointestinal, biliary, and urinary tract obstruction. Okay. The easiest will be the presence of jaundice. Kagad, you suspect biliary tract obstruction, okay. Without jaundice, you suspect either gastrointestinal and urinary tract obstruction. If there are cues that there are urinary disturbances, then you think of urinary tract obstruction. Kung wala, you think of, especially if there's vomiting, abdominal, no bowel movement, then you think of gastrointestinal obstruction. So after you get these initial cues, you have to analyze further through more data gathering, okay, more symptoms, more signs, okay, and repeated questioning and doing physical examination until the diagnosis is quite certain whether there is really obstruction and then the type, whether it's gastro, biliary, or urinary, and the specific cause, whether it's due to a tumor, stones, and others. So look for cues for a specific cause or disease causing the abdominal obstruction after you suspect abdominal obstruction. Okay. Then use the pattern recognition of a particular disease and prevalent process in those with similar presentation of symptoms and signs. For gastrointestinal obstruction, as I said, the cues will be abdominal pain, vomiting, abdominal distension, and no bowel movement. Okay. So first, palpate for a mass in the abdomen. If there is a mass, most likely that will be the cause of the obstruction. And then determine the location of the mass. Okay. The location of the mass can give a clue as to the specific site of the obstruction. If no mass is palpated, you consider adhesions in patients with history of abdominal operation. Okay, basta no mass, and then if the patient has history of abdominal operations, then we consider adhesions as a possible cause. Then if there is no mass, no previous operation, then you use the other data. Use the color of the vomitus as cues for the site of the obstruction. Okay, this is another cue. If the vomitus is not yellow-green, okay, then you suspect an obstruction at the stomach level. Okay, but if the vomitus is green or yellow, may bile na siya, then we suspect a obstruction below the stomach, usually in the intestine, small intestine already. No? So for biliary tract obstruction, again, the first thing to do to analyze for the specific cause will be to palpate a mass in the liver area. Okay, if there is a mass in the upper quadrant, okay, then you suspect the mass as the possible cause, and then check if it's coming from the liver. If it's coming from the liver, most likely that's the specific cause for the biliary tract obstruction. If there is no mass, then you look for symptoms of gallbladder disease, okay, with stones in the biliary tract passage or pancreatic tumor. Okay, so kung walang mass, explore further and look for symptoms that might suggest a gallbladder disease. Okay, usually right upper quadrant pain. Okay, and then or a pancreatic tumor. Okay, if the patient is manifesting signs and symptoms of pancreatitis. Okay, for urinary tract obstruction, again, the first thing to do is to palpate for a mass. If there's a mass, then think of it as a possible cause. If there is no mass, then you look for signs and symptoms that will be suggested. Kasi if you don't palpate any mass, it does not rule it out. Baka masyadong maliit. No? So you still have to look for symptoms that might suggest a mass or a stone causing the obstruction. And look for the associated symptoms, which may give clue to the urinary tract obstruction. Case illustration. Starting point, as I said, starting point in the evaluation, patient has an unpleasant sensation in the abdomen with no history of trauma. Okay. So case number 1, patient presents with persistent abdominal pain, persistent vomiting, ituloy-tuloy ang vomiting niya, progressive abdominal distension, lumalaki ang tiyan niya, and then progressive difficulty in bowel movement. So right away, you think of gastrointestinal tract obstruction. But it may also be due to non-gastrointestinal obstruction. Okay? But you suspect it first. Then you look for more cues, more symptoms, okay, that will suggest obstruction. So if there's a palpable mass, then you think of the mass as the cause of the obstruction. Okay. So now, if there is the mass that you are able to palpate, then you consider the location of the mass. If the location of the mass is in the epigastric area, meaning here at the center, then you think of the stomach and the pancreas. Okay. If on the right upper quadrant, you still think of the stomach kasi umaabot yung stomach to sa right, the pancreas also, okay, small intestine andyan, okay, and then the large intestine andyan pa rin, okay. So in this patient, walang jaundice. That's why you don't consider yung liver, no? Okay. Now, if you have a mass in the right lower quadrant, left upper quadrant, left lower quadrant, and periumbilical sa gitna, around the navel, then you think of the small and large intestine. So you localize the mass, okay, and then try to come out with a more specific diagnosis based on the location, and which is usually based on the anatomy, kung nasaan yung mga organs. So another illustration, patient presenting with jaundice. Okay. Right away, you start thinking of biliary tract obstruction. But again, it may, this is just one data, one single data. So, but still think of biliary obstruction. But mind you, it may still be due to non-obstructive jaundice like hepatitis. Okay. So evaluate first for possible obstruction before settling for non-obstructive cause. Okay. So yan ang algorithm. No? Mauna muna yung ruling out possible obstruction before you settle for a non-obstructive jaundice. So the cues for a biliary tract obstruction, again, presence of a mass in the right upper quadrant and history of gallstones. Kung meron siyang previous gallbladder ultrasound that shows gallstones. And another cue will be colicky ang abdominal pain niya, especially on the right upper quadrant. Okay, so all these cues will point to a biliary tract obstruction. Okay. Another illustration, this time urinary tract obstruction. For male patient, common cause based on prevalence is prostate disorder or disease, either benign prostatic hypertrophy or prostatic cancer. So palpate the abdomen. If there's no mass, think of prostate as the most probable cause. Okay, benign prostatic hypertrophy or prostatic cancer as a possibility. There is a mass in the hypogastric area, in this area, you think of urinary bladder. Andiyan kasi yung bladder mo di ba? The prostate is still deep down there. Mahirap kapain yun, no? On the abdomen. Okay. So, paraclinical diagnostic procedures for abdominal obstructions. Common instrumental and laboratory diagnostic procedures for abdominal obstructions will be the following: imaging procedures, X-rays, plain or with contrast dye, and then ultrasound, CT scan, MRI, PET scan, etc. Okay. So the other common diagnostic procedures will be endoscopy, okay, upper and lower endoscopy. For upper, it's usually used to scope the esophagus and the stomach. For the lower, it's usually used to scope the large intestine and the rectum. Okay. Then you have the blood tests like CBC, liver function tests, tumor markers, etc. So there are a lot of tests that can be done for abdominal obstructions. Okay. The foremost indication for a paraclinical diagnostic procedure can be stated this way. If you are not certain on the primary clinical diagnosis, let's say you have evaluated the patient, you suspect something, then you have your primary and secondary diagnosis. Okay. Even with the primary diagnosis, you're not quite certain. That means you're not, let's say, less than 90% sure. Okay. And you need to be more certain or be more certain before the treatment. Then there's an indication to go for a paraclinical diagnostic procedure. So to decide on the indication for a paraclinical diagnostic procedure, the physician uses two processes: the degree of certainty on the primary clinical diagnosis and comparison of treatment plans for the primary and secondary diagnosis. Okay. And as a rule, there is no need for a paraclinical diagnostic procedure if you're quite certain of your primary clinical diagnosis and the treatment plans for the primary and secondary diagnosis are the same. The competencies required by physicians managing abdominal obstruction. So they must know the uses and indications of all known instrumental and laboratory diagnostic procedures for abdominal obstructions. Marami yan, okay? And then they must know how to use them as needed and as indicated. And they should be guided by the BRCA process, okay? Benefit, risk, cost, availability, comparative data of the different options, and then try to choose the most cost-effective one, okay? And then they must also know how to interpret the results, no, on them by themselves or help you interpret it. So this is the illustration of the BRCA process. Okay, B stands for benefit, risk, R risk, C cost, and then A availability. So basic treatment modalities for abdominal obstruction. Okay. So basically there are three treatment modalities: surgical, non-surgical, potentially surgical. Surgical means the treatment is outright operation. Non-surgical treatment is outright no operation, just medical, okay, just gamot or watchful waiting. Okay, so the other basic modality is that you can have the stance of watch and wait, and then if it progressed to a surgical condition, then it's called potentially surgical treatment. Okay, surgical only when needed. Okay, so three categories. So examples of conditions, abdominal obstructions needing outright surgical treatment or needing outright operation kagad. Okay, so these are in patients with complete intestinal obstruction causing sepsis, infection, or may rupture, nakapumutok. Okay, so dapat gawin kagad yung operation. Complete biliary tract obstruction causing sepsis. Okay. Complete urinary tract obstruction causing sepsis and may cause serious kidney disease. So these are the more common examples of conditions in which an outright surgical treatment must be done. Okay. And then the type of surgical treatment that are usually done will be removal of the cause of the obstruction, either direct or indirect through a bypass. When you say remove the cause of the obstruction, for the intestinal obstruction, if it's caused by the tumor, you remove the tumor. If it's caused by stones, you remove the stones. Okay. If the tumor cannot be removed, then you have to do a bypass. Okay. Para dumaan pa rin mga pagkain. No? Okay. So the other type of surgical treatment is drainage of infections. Okay. So there are times in which the infection, the abscess, can cause abdominal obstruction. So it has to be drained. Examples of potentially surgical treatment in which a watch and wait stance is a better option, in which the medical management can be tried first, will be the following: incomplete. Kanina, yung first example on outright surgical is complete. So this time it's incomplete. Okay, gastrointestinal obstruction, incomplete biliary, incomplete urinary tract obstruction. Okay. So baka pwede pang bantayan mo na. Okay, it might baka mawala, no? Okay. Now, outright non-surgical, meaning hindi kailangan ng operasyon. Okay. So there is complete or incomplete intestinal obstruction, biliary obstruction, urinary tract obstruction, but in which the cause cannot be operated or removed or too risky to operate. So right away, you will say, hindi na kailangan ng operasyon because it's too risky. Okay. So you can make use of some medicine as a supportive management, or kung walang effective medicine, just watch and wait, okay, with natural support management. So this is an example of the BRCA process in selecting the most cost-effective treatment. Again, you list down all the options here and then compare the options in terms of benefit, risk, cost, availability. So summary and takeaway in this talk, I have discussed all of these topics: abdominal obstruction, what is it, different types, causes, how common, clinical diagnosis, paraclinical diagnostic procedures, and basic treatment modalities for abdominal obstruction. So takeaway in relation to patient empowerment: be always in touch with reliable medical information on fundamentals and generalities in medical management of abdominal obstruction. Knowledge is power. It gives power. Use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management of abdominal obstructions. So with that, I end my pep talk. I hope I have empowered you to have a better understanding of the fundamentals and generalities in the medical management of abdominal obstruction. Before we go to the QA, reminder, take the OLETE for Mastery of Learning. 50 OLETE certificate will entitle one to have one voucher for RO telemedical consultation. I think we're now on the 44th lecture. Okay. So now let's have a group picture taking before we start the QA and interactions. Okay, ready for the picture taking, everybody? One, okay na? Wala nang pahabol? 1, 2, 3. Oh, may pahabol pa si Aida. Andali. Ulitin ko lang ha, may pahabol si Aida. Nagpahabol si Aida. 1, can you show your face? 1, 2, 3. Okay. Okay. So the floor is now open for questions, comments, anything, or consultation. Short consultation will do. Okay. So today we discuss abdominal obstruction. When you say abdominal obstruction, barado sa abdomen, but basically it consists of 3 areas of obstruction: the gastrointestinal tract, no, yung stomach. I did not include esophagus. Saka na lang yun kasi yung esophagus is not inside the abdomen, no? Okay. But it's part of the GI tract, no? Pag barado yung esophagus, ganun din magbabamit ka pa rin, no? Okay. And then the other area will be the biliary tract obstruction, and then the urinary tract obstructions. Okay, these are the more common types of obstructions that we deal with in abdominal obstructions. Meron pa ba kayong naisip na different types of obstruction sa tiyan? Yung barado sa fallopian tube, hindi ko na sinama rito, ha. Minsan pwedeng barado yung fallopian tube, no, sa mga babae, no. Okay. So it can cause infertility, ganoon, tama? Okay. So I did not include it in this discussion. So any tube, any channels in the abdomen, there's always a possibility of the problem of obstruction, because as we said, obstruction is the blockade or impediment of passage of something through a tube. No? Okay. Anybody who wants to share their experience? Any questions? Sinong na-operahan na sa tiyan?
Si baby.
Baby, appendectomy.
Hindi, iba pa ho yun. Puro tahi na yung tiyan ko, Dok.
Okay. So, ang kalaban mo, possible, pag nag-obstruct ka. Ano?
Sabi Hillary, ito, nakalimutan ko na, Dok eh. Parang namaga yung esophagus ko.
Esophagus, hindi. Yung sa tiyan, okay. Ang operation mo, for esophagus,
Oho, Hillary, di ko na matandaan, Doktor, 2 years ago.
okay. Bandang itaas
Ano yun, nagbabara yung kinakain ko, tapos na machochok ako, masusuka ako, hindi ako makahinga. Ganon.
Okay. Yeah, achalasia ang tawag doon. Achalasia.
Achalasia.
Diba? Achalasia, diba? Sa esophagus. Okay. Sa itaas yun. Okay. So that's why I did not include it here. Sa esophagus yun. No? Ano?
Mahaba yung aking hiwa eh, from sa ilalim ng breast hanggang sa may ibabaw ng pusod.
Okay. Okay. So, okay. At tinatanong ko silang sa iyo kanina, sa inyo, kung sinong may operasyon sa tiyan. Sabi ni Beth, si ikaw. Okay? So, what I want to emphasize, just to reinforce my lecture, kung meron kayong operasyon sa tiyan at nagba-vomit kayo, no? Okay. And then you cannot really, basta sigurado kang hindi, yung sakit ng tiyan mo is not due to the previous condition that you were operated on, no? Most like, at wala namang bukol, ganun, no? So, you think of adhesions. Yung mga kasi pag ginagalaw yung bituka through an operation, minsan dumidikit-dikit yung mga bituka sa loob, no? So, wala ka na magagawa doon, you just pray and hope na hindi mangyari sa iyo, no? Okay. Any question at the chat box, Abet?
Wala, Doktor. Pero sabi ni Christy na operahan daw siya.
Si Christy. Okay.
Christine Joy Legaspi. Gallbladder yata.
Gallbladder. Okay. So gallbladder. Okay. So bihira naman. Pwede pa rin mag-adhesions dyan. Ha? Basta may operation. As a rule, pwede pang magkaroon ng adhesions. Pero bihira yung yung gallbladder kasi nasa itaas lang, di ba? Yung pinasukan ng operasyon ng surgeon mo sa itaas lang, no? Okay. Tama? Sa itaas lang, sa right upper.
Yung sa akin po kasi tatanggalan ako ng gallstones. So kaya po kailangan tanggalin.
Kaya nga yung hiwa mo nasa itaas lang, di ba?
Apo, nasa taas lang po siya.
Okay. Okay, ganun yan. No? So, kung minsan yung hiwa, dito lang. No? Okay. Yung iba naman, yung hiwa, dito. Okay? Buong tiyan. No? Okay. So, pag ginalaw yung buong tiyan nyo, no? Mas malaki ang chance to have adhesions. No? Okay. Mas malaking chance lang. Pero exact, nobody can tell when kung kakaroon kayo hindi, no? Pero dito naman, pag dito lang, kasi hindi man pumapasok yung kamay ng surgeons pababa, di ba? Dito lang sila, no? So konting adhesions lang yan dyan, kung meron man, no? At usually, hindi na apekto yung mga, kasi adhesions usually affect the small intestines, no? Nagbabara sa small intestines, no? So, may small chance lang ito, no? Okay? Clear? Yan lang i-emphasize ko, no? Okay. So, gallbladder. Gallbladder. So, bakit ka na-operahan? Hindi siya obstructed.
May ano po ako, may gallstones po ako.
Yan nga.
May nakita pong gallstone sa akin. So, yung akin po kasi maliliit. So, in tendency po niya, kaya po siya tatanggalin dahil sobrang liit niya, pwede siyang, kasi marami na po siya eh. So, kailangan natanggalin talaga.
Sumakit ba?
Tagal na po kasi yun eh.
Okay.
Tinanggal po.
Okay. I will be discussing that in the future, yung gallstones. No? Okay.
Apa.
To operate or not to operate. Parang yung mga polyps, no? Okay. To operate or not to operate. Gallbladder polyps. No? Okay.
Apa.
So actually there was a question on gallbladder polyps last time. No? I think si Jocelyn T yata, no, nag-question, no? And he was able to teach somebody, to advise somebody not to have it operated on, no? Okay. Gallbladder polyp, no? Okay. Yung gallstones, pag merong gallstones at wala kang nararamdaman, actually you don't have to have it removed also. But I will discuss it in detail. No? Okay.
Yung sa akin po kasi, Doc, ano na ako eh, bale, sobrang sakit niya na talaga, hindi ko na siya matolerate. Tapos, ano na po talaga ako, tawag ito, hindi na po ako makakilos talaga. So, sobrang sakit niya, kaya kailangan ng tanggalin.
Okay. Yan ang indications. Okay?
Opo. Sobrang painful niya. Tsaka, ano po, hindi na po ako makatulog nun eh. Kaya sabi nung doktor ko, parang, we need to remove na kasi sobrang dami niya na talaga. Pinakita niya naman sa amin yung sample po, yung tinanggal. So
Okay.
talagang marami po talaga. Maliliit. Para siyang paminta po sa sobrang liit.
Okay. Mahilig ka pala sa paminta. No?
Hindi
Okay.
naman po. Maliliit talaga siya.
Okay. Okay. Thank you for sharing. Okay.
There is one from Rochelle de la Cruz. Hello, Doc. Good afternoon po. Katatapos ko lang po ng annual medical check and part is the ultrasound of the whole abdomen. Normal naman po ang results pero lagi po akong constipated. Ano po ang test na pwede kong i-check whether may obstruction?
Okay. Okay. Constipation. Okay, that's the starting point. Tama ang evaluation. So, you have to determine ano yung cause ng constipation. No? Okay. So, constipation can be caused by a disease such as a tumor or others. No? Basta disease. No? But the other category of causes will be yung tinatawag na non-specific or functional. Ibig sabihin, wala talagang definite na sakit na dapat gamutin, na dapat tanggalin. No? It's because of your probably lifestyle. No? Okay. So yung mga kinakain mo, palagi nagkakos ng constipation. And then yung character mo, palaging nervyosa or stressful. Kimisan, yung stress niya can cause either diarrhea, frequent diarrhea, or sometimes constipation. Okay? Or yung habit mo talagang hindi ka, kasi may mga tao may habit na ayaw dumumi everyday. No? Parang ilag sila doon. Gusto nila, dumumi sila every 3 days, every 4 days. No? Ayaw nila pumunta ng banyo. No? Di ba? Merong taong ganon, di ba? Okay. So that's an example of the other category of cause, no? Na wala naman talagang sakit, but it's because of some disorder in yung ano lang, yung lifestyle, no? Sabihin na lang natin lifestyle or non-specific, no? So you have to determine kasi kung paano yung ano yung clue that you're dealing with the disease, no? Okay. Once you have a constipation that is progressive, no? Ibig sabihin, lumalala, no? Okay, tuloy-tuloy at lumalala. And then kung may associated symptoms of may dugo, no? Okay, lumiliit yung caliber of the stool, no? Di ba, may yung mga ibang matataba and then bigla nang liliit, no? Yung stool, no? Then there might be a medical disease, no? Causing the constipation. Okay? Kung wala naman, we just observe lang. Pwede naman i-observe lang because it's functional, no? So you just adjust your diet, your lifestyle, no? Choose the food, yung mga pagkain mo, probably eat a lot of high fiber diet, no? Okay. And then a lot of fluid, no? Okay. Ngayon, kung talagang gusto mong siguradong walang problema sa constipation mo, no? Okay. If you really want to have a test, no? Ang tanong mo, what test? Probably the most direct way is to do a colonoscopy, no? Okay. Or to check, yung sisilipin yung large intestine mo. Okay? Okay. Kung talagang gusto mo. Pero as I said, you have to determine what are the chances that it's not, it's just a parang non-specific cause lang. No? Kung non-specific cause, you don't have to go for the test. No? Okay? Sinagot
Salamat,
ko.
Doc. Yes po.
So anong klaseng constipation meron ka?
Hindi po naman kasi siya palagi, Doc. Actually, Doc, I have a habit of checking yung color and yung size po ng stool ko every time. So, okay naman po siya. Kaya lang talagang hindi ko alam kung mula kasi pagkabata po ako, hindi ako regular, as in hindi po ako everyday. Pero lately po kasi, tama po kayo doon sa, yung nakaka-relate po ako doon sa sinasabi niya about lifestyle kasi medyo stressful po kasi sa work ngayon eh. So, mas parang nagiging, yung epekto niya, nagiging lalo po akong constipated.
Okay. Okay, that's good. So, that's good. Thank you for the question. Lahat naman kasi, I think lahat tayo may constipation. No? Okay. Kaya yung nilagay ko doon sa aking slides, the cues for gastrointestinal obstruction, I try to avoid the word constipation kasi malabo, very vague. So very general yung constipation. Ang pinaka-reliable cue, yung talagang wala ng dumi lumalabas. No? Okay. So kung wala ng dumi lumalabas sa puwet mo, hindi ka makadumi, then that's the time you suspect strongly intestinal obstruction. No? Okay. At kung mayroon pang lumalabas, so kumisan, mahirapan dumumi, no? Maraming interpretation dyan eh. No? Okay. So I guess all of us have experienced constipation at one time or another.
Yes.
Minsan once a week. Okay, di ba? Dahil sa pagkain natin, baka sa pagkain natin, di ba? Okay. Ako, nararanasan ko rin yun. So, is there somebody who has found a strategy in which hindi siya magko-constipate for 5 months, 6 months, 1 year? Meron ba? Baka at least once a month magko-constipate tayo lahat. No?
Yes.
Tama? Pero hindi natin pinapansin, di ba? Kasi mawawala naman after 1 week or after 2 days, 3 days, mawawala na naman yan, di ba? Kuminsan dahil sa pagkain lang natin yan eh, di ba? Okay. Okay?
Salamat, Doc.
Okay. Any more?
Nothing at the chat box.
Okay. So, if there are no more questions, wala na talaga. 3 o'clock na rin. No? 3:03. If there are no more questions, we'll call it a day. No? So the next topic will be bleeding na, no? Gastrointestinal bleeding, no? And after that, jaundice, no? Jaundice. Okay. So if there are no more questions, wala na, last call?
There is none.
Okay. Okay. Good day and have a nice weekend. Okay. So we'll see. We'll see next week ulit.
Okay.
Bye-bye.
Thank you, Doc.
Bye.
Thank you.
Bye-bye.
Thanks, Doc.
Hi.
God bless, Doc.
Yeah, kayo rin.
Bye, Doc.
Bye-bye. Okay.
Thank you, Doc.